and all these things. थोड़ा सा वेट कर लेंगे.
मैं पीपीटीज आगे पीछे करूं क्या, जिस आइडिया हो?
आप कर सकते हैं.
अभी आई कैन नॉट सी, आप बताओ हो रहा है ठीक? आई एम चेंजिंग नाउ.
या सही है. So sir,
And doctor is,
I am just sharing you
are
the
you,
stream key. Okay.
sir, wait for a minute. Wait for a minute. Doctor, are you there in the place where you take the live session? Is it the same place?
हाँ यस सर.
So that the Wi-Fi connections, etc., it is proper.
नहीं नहीं सर, आई एम गोइंग टू टेक लाइव सेशन एट दिस प्लेस ओनली बिकॉज हियर आई पुट द कर्टन ऑलरेडी. दैट इज व्हाई आई एम सेइंग.
Yeah. Okay. Okay. Sir, then please check the this one lagging. It is good.
Sir, it's absolutely super smooth, I can say.
No, the thing is everything will be super smooth in the initial time. We need to check after.
Yeah.
There only will be the problem.
Yeah.
Yeah, sir.
We need to
So I
check
have shared you that one. Okay, link. So yeah, you
So
can
sir, that YouTube
ask
practice
ma'am to.
session
Yeah.
which you have told, वो अभी होगा या tomorrow sir?
अभी मैम यही है, मैंने ऑलरेडी स्टार्ट कर दिया है.
No, no, no. Actually, today also we will be checking. By tomorrow also we will be checking. And by day after tomorrow, while you go for the live session, before that you will have 2 or 3 sessions, I feel. After that, for the 12th session is there. Now for 12th session, you will be not having these things. You will be meeting us 30 minutes prior because you used to get to all these things. Now, how many times we need to repeat the same aspects?
So sir, this you will be sending me now in the PDF form, right? This whole PPT you already have.
No, we need to edit this. Actually, you send me this PPT once again.
Once again, I should say. Okay.
Yeah. We need to edit something like we haven't given the Instagram, Facebook, or YouTube for this one links here, so that we'll be adding to this PPT, and I will see whether you will be used to this PPT or we need to change it to a PDF or something like that. We'll be planning by tomorrow and today, exactly with which you are comfortable. Okay.
Because sir, now
We need to
PPT is
know
also
this.
comfortable for me. That's why I'm saying. So if you see, because
So,
I'm
doctor,
changing, so yeah.
no. What we'll be doing now, doctor? Like you feel that you are taking the live session now itself. So,
Sir,
what you'll be doing is.
the problem in this presentation is, sir, that can you see click to add title? Since we are not starting the slideshow, no, these things will be there.
That will be not an issue.
No,
No,
ma'am.
what we
We
want
will
to do
remove
is.
it, ma'am. We will remove it.
No, what we are looking now, doctor, we are looking at whether the internet connection it is going to get fluctuated. First of all,
Yes, sir.
next
I
what we,
understand. Yes, I understand that. But sir, if I'm not doing it on a slideshow, suppose I have to write something over here, na sir. See, like this, I have to go. Then this
yes,
is
yeah.
going to be a problem. I am not getting the good space to write.
मैम आप एक मिनट मैम, मैं वही बोल रहा हूँ कि इसको हम लोग क्या करेंगे ना कि अभी जो वहां पे लिखा आ रहा है ना क्लिक टू ऐड टाइटल, उसको हम लोग आपको रिमूव करके दे देंगे.
मिस्टर सागर, ये ऑलरेडी मेडिकोस कम्युनिटी की तरफ से ऑलरेडी आ चुकी है, ये वो वाली स्लाइड है.
नहीं मैम, इस बार जो आएगा ना आपको वो मैं करके दे दूंगा एडिट. इस बार जो आएगा वो मैं आपको करके दे दूंगा एडिट. उसमें
Doctor,
ये
this
सारा कुछ नहीं रहेगा.
no, you will get the new this one PPT or PDF. In that you will be getting the exactly. I can understand what you are trying to say.
Yes,
So that we'll be taking all those steps and we'll be giving you the edited one. Okay.
Because
There'll
this
be
is
no
by
issues.
default coming on the slides when we are making the slides. Only just slideshow.
Yeah.
We press, then this thing goes. That is
In the sense, it is not under your control, I feel. Am I correct?
What, sir?
It will be not under your control.
Yes, because only this click to add title is by default in the PPTs. I don't know if anyone can remove it. It goes only on the slideshow button.
The thing is, Sagar, we will be checking with her whether she will be convenient with the scrolling down of the slides in with respect to PPT, or we'll be checking with the PDF as well. So, if she is comfortable with this PPT, then you need to edit this particular edit data. Click to add data. Something is there. Now you edit that.
ओके मैम. या आई हैव अंडरस्टूड. तो मैम आप ऐसा करिए ना कि अभी मैं आपको बता दे रहा हूँ कि ये कैसे रिमूव होगा. ठीक है, ताकि आप भी थोड़ा कंफर्टेबल हो जाए. तो मैम मेनली ना आप ये जो पतला सा वो है ना थिन लाइन, वो मतलब कि बॉक्स का क्लिक टू ऐड टाइटल, वहां पे एक बार क्लिक कर दीजिए.
No, sir. Anyhow, we are going to edit that now. Why you are getting this stuck to these things? These are all
Okay, okay,
unnecessary, I
okay,
feel.
okay, okay. No issues.
Anyhow, we need to
Okay.
edit. I will be editing that. Why we need to waste this time with these aspects?
Sure, sure, sure.
Better you check with the internet connections. Doctor, you proceed with the 5 or 6 multiple choice questions, okay? So that then only we'll be coming to know what it is happening with the connections.
So you want
Five
me to
or
do what, sir?
you proceed with 5 or 6 multiple choice questions.
I should speak or just I should move the screen?
As
No, ma'am,
usual,
you have
what
to
we do in the
speak
live
only.
session. Now, what we'll be doing now, we have created one dummy channel. In that dummy channel, the session will be live, so that it will be seen by the only people who are having the access. And what we'll be doing is we are proceeding just similar to the session what it is supposed to happen. So you need to proceed with 5 to 6 multiple choice question for that purpose. Then only we'll be coming to know exactly regards to this connection and all. So that at the end of the session, Sagar will be saying whether it is super smooth or not.
Okay, sir. Just give me 1 second.
Openly, yes, I got used to the PPT.
So, sir, I have
What?
shared the a link with you, so you can also check.
No, I will be checking, sir.
So which of the following is not in quadruple test
Wait,
for
wait, wait, wait,
anti?
wait, 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 wait. Sagar, has you started the stream?
Yeah, yeah, yeah,
Can she proceed?
yeah, yeah, yes, he can.
Yes, doctor, proceed ahead.
So question number 1, which of the following is not in quadruple test for antenatal detection of Down syndrome? The options are alpha fetoprotein, beta HCG, estradiol, or inhibin B. This was a question asked in AIMS 2018. So answer is inhibin B. Remember, quadruple test is a second trimester screening test which includes the alpha fetoprotein, unconjugated estradiol, HCG, and inhibin A. So not inhibin B. Also know that the quadruple test is done between 15 to 20 weeks and the mnemonic high can be remembered. That means the HCG and the inhibin. HCG and the inhibin, they are going to be increased. H and I. So they increase and that is these two will increase and these two will be decreasing. This is only for Down syndrome because that's the most common they ask. For other syndromes, almost all the 4 values are decreasing only. Only for Down syndrome, this high mnemonic can be remembered.
Because that's the for other syndromes, almost all the 4 values are decreasing. Only for Down syndrome, this high mnemonic can be remembered. Doctor, use your listen pen tab. Where is your pen tab? For
I'm
other
using my
syndromes,
pen tab only,
almost
sir.
all the values are
I'm
decreasing.
teaching with that only.
Doctor, use your listen pen tab. Where is your pen tab? For other syndromes, are you using?
Yes, sir. I'm drawing with that, writing with that only.
Doctor, use your listen pen tab. Where is your okay, proceed, proceed, proceed.
The voice is echoing, sir.
Yes, proceed, proceed ahead. Sagar, do you see? No, Sagar, do you see that pen tab? Are you writing something with the pen tab actually?
Sir, I wrote now just now.
Because I
writing.
couldn't see that. Something you write near to that. Yeah. Proceed, proceed, proceed. Sorry for that.
I'm writing. I wrote on the previous screen. Was it not visible?
No, I haven't seen. That is, yeah. Proceed, proceed.
I had
Sorry
to
for that.
answer all this. Yes.
Yes. Proceed. And doctor, in the actual session, you need to give certain introduction regards to this medicos community. Actually, you could see that with the other live sessions as well. And you need to say something related to course which are being introduced to this.
So post related to what, sir?
In the sense, the courses, in the sense, the different courses and early bird offer which are being this one enforced by medicos community, you need to say something related to that. And the things you can see that with the live sessions of the Dr. Shruti or Dr. Saujanya with the actual YouTube channel itself.
Okay, sir. already the
Getting
promo video content has been given. That only, sir, we have to speak now.
no, 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 no. That is entirely different. That is entirely different. That is a promo video which are using for the marketing purpose. Here you are seeing in front of the live session. I am saying.
Okay, sir.
आओ ठीक है सब नहीं
Okay, sir.
In the live session, in the sense like before starting with the first question, you are supposed to interact with the students, something related to medicos community, and in the sense this particular session it is related to NEET PG 2023, but you need to say something related to the different courses which are being enforced by the medicos community and the early bird offers which are being given by the medicos community. In the sense, in detailed description, you can see with the live session which are happened previously happened. You can check with the Saujanyas or you can check with the Shruti's live session, so that you will come to know what actual part which you are supposed to say before starting the particular session. Getting my point?
Yes, sir. Yes, sir.
Yeah. Yeah. So I hope you are not ready for that. By tomorrow, before you start the session, you please go through those live sessions of Dr. Sojanya or Dr. Shruti, and you please be prepared for that. You entirely need not copy those of what they said. You kindly change to your own notes, and you update that particular aspects before tomorrow evening session. I feel.
Okay, sir.
Yeah. Sagar, check with the connections and doctor will proceed ahead. I don't have any objections.
So the double marker test and triple marker test, that means maternal alpha fetoprotein, HCG, and estriol. And in this only, if we add the inhibin A, then that will become the quadruple test. Remember, triple test is now kind of obsolete. We do either the double marker test or the quadruple test. Double marker test means beta HCG and PAPE will be the answer. Second question, what is AMTSL? That is active management of third stage of labor will include all except so ergometrin after anterior shoulder delivery, uterine massage, quad traction, or oxytocin infusion. This question is again from AIMS 2018. And uterine massage is the answer because active management of third stage of labor means immediate administration of prophylactic uterotonics. Every time you have to select this pencil. Immediate administration of prophylactic uterotonics, control for traction during placental delivery, delayed cord clamping, and intermittent uterine tone assessment. So that means this tone assessment is not the same thing as massage, and uterine massage is not the part of AMTSL. Now, this is what I'm saying. Can you see this overlap is there? But take care of it, okay? Hello?
Yes, Sagar, have you seen that?
So this is point what I'm trying to emphasize.
Yeah, I got that. I got that.
Yeah.
In the sense, click the text here, and your question is overlapped with that particular aspect.
yeah ma'am we will clear all these things
Yeah, we'll clear that. Not an issue.
So
You proceed.
next question is 28 weeks pregnant female has come and on examination the umbilical artery is showing this image. So what will be the next step in management? So if you see umbilical artery, these are the images. This is the pic you have got. Okay, this again question has been asked from AIMS 2018. And before we go into the answer, let's see these images. So it is, if you see, this is a systolic blood flow and this will be the diastolic blood flow. Systolic blood flow, diastolic is this much only, okay? So remember, if you see, this is kind of decreased. A normal peak will have at least 1/3 of the systolic value, but it is less than the 1/3 of systolic volume, the diastolic flow, okay? Remember, in pregnancy, the uterine artery, even the diastolic flow will keep on increasing because we want to give lot of blood to the baby. But suppose there is not sufficient diastolic flow in the uterine artery or the umbilical artery, then that is suggestive of IUGR. So if you see this decreased your umbilical artery blood flow in this, there is or it is absent diastolic blood flow. And if you see there's a reversal in fact, okay, reversal of end diastolic blood flow. So these are the three ultrasound wave velocity forms you should know. A is decreased, B is absent, and C is absent end diastolic blood flow. And depending on what stage the patient comes to you, the management will be different. So now you're suspecting a case of fetal growth restriction of less than 38 weeks. Why? Because less than 38 weeks, more than 38 weeks means definitely termination of pregnancy has to be done. Less than 24 weeks means you will deliver if the maternal situation is very serious, or else you can repeat sonography every 3 to 4 weeks. But if it is more than 24 weeks but less than 34 weeks, in this scenario, you have to evaluate the maternal status and other comorbidities like hypertension, diabetes, etc. You will see the umbilical artery Doppler, which I just now have showed you. You will see the fetal testing by the NST, that is a non-stress test, and biophysical bioprofile. And you will consider steroids for lung maturity because the baby is less than 34 weeks. Now, you will consider delivery if the baby is less than 34 weeks and there is reversal of end diastolic flow. Okay. So, just now I showed you this is systolic. And if there's reverse in the diastolic flow, okay, suppose this is a baseline, the diastolic flow is going in the reversal and the baby is less than 34 weeks, you will terminate that pregnancy. Or, of course, there is non reassuring fetal heart rate or any maternal situations are serious enough. So, you will deliver in these three scenarios when the baby is less than 34 weeks. Now, if there is no such indication, that is fetal and maternal, they are healthy. So what you will do? You will actually just do a good surveillance by regular fetal testing. You will do a weekly umbilical artery Doppler and weekly evaluation of the amniotic fluid because amniotic fluid is again a part of biophysical profile. And every 3 to 4 weeks, we will see the baby for growth. The growth parameters we know are the head circumference, the abdominal circumference, the biparietal diameter, and the femur length. These are the growth parameters which don't need to be done very frequently. They will be done every 3 to 4 weeks. But the Doppler and the amniotic fluid, they will be done every week. And if the fetal growth is occurring and you're satisfied, then you can continue till the 34 weeks of pregnancy. But if now the growth is also poor, then you can again consider delivery. Now, suppose the baby is more than 34 weeks, but less than 38 weeks. Okay. So now you will again see how's the maternal situation, how's the umbilical artery, and how's the baby doing. Now, if there is absent or reversal of end diastolic flow, okay, AREDF. So it means absent or reversal of end diastolic flow. That means that you have to deliver the baby. In this situation, even absent diastolic blood flow is an indication for delivery as compared if the baby is less than 34 weeks or the baby is oligohydramnios having non-reassuring fetal heart rate or any other maternal serious condition is there. So these are the indications for delivery. And since the baby is more than 34 weeks, the steroid cover is not necessary for lung maturity. But if there are no such indications, which we saw just now, then again a fetal surveillance is required. And how do you do that? At the same regular fetal testing, umbilical artery weekly monitoring, and amniotic fluid weekly monitoring. And for growth, every 3 to 4 weeks you will do. If the fetal growth is sufficient, everything is fine, you will deliver by 38 weeks. But again, if there is no growth, you can consider delivery at that time point itself. Sir, I hope this much is enough, or you want me to continue?
No, actually, what happens now, doctor? How much question you have finished? Three, right?
Yes,
Two
sir.
or three? No, in the sense we'll come to know regards to lag when you proceed with 15 minutes or something like that. So I need you to
Okay.
proceed with next 2 or 3 questions.
Right, sir. I'll do that. Okay.
Yeah.
So now coming to the option, if you see the question, so the patient is now aware of 28 weeks, okay, and umbilical artery is this. So basically, the question requires you to even know how to read the ultrasonography, okay. So if you remove this, okay, so if you remove this, you can see that there is no diastolic flow, okay. So what is the umbilical artery flow explaining it to you? It's a absent, okay, absent end diastolic flow, right? Because there is absolutely no end diastolic flow and it is not reversed. It's not reversed. So if you remember the just now I discussed with you, the patient is 28 weeks and it is absent end diastolic flow. So it is not an indication for termination. Had it been a reversal of end diastolic flow, we will terminate the pregnancy. So what will you do? Will you terminate immediately? No. You will give steroids and monitor with Doppler and biophysical profile and planned delivery. Give steroids, cover, and take up for cesarean immediately. Go for normal vaginal delivery as the baby is very small. So now I hope the answer is very clear. The answer is option B. Give steroid cover and monitor with Doppler and ultrasound and planned delivery. So now suppose a similar question is asked to you. Here, the question is saying that the placenta is grade 3. The POG or the period of gestation is now 35 plus 3 weeks pregnancy. And now there's absent end diastolic flow. Again, this means absent end diastolic flow, right? What will be the next management? So nothing has changed, just the period of gestation has changed. And that will change the whole management. That means now you will talk and terminate the pregnancy, okay? Dexamethasone has no role after 34 weeks because we know that lung maturity happens. Terminate after 37 weeks. There's no point of waiting because absent and diastolic flow after 35 weeks is again an indication for termination. Monitor and do nothing. So this again means the answer is talk with pediatrician and terminate. Why pediatrician? Because of course it's an IUGR baby and NICU is very much required. That is why a delivery at a tertiary center is required. So moving to the next question. Question 4, longest fetal diameter is what? So it's a very straightforward question, but again, it's very important to know all the fetal diameters because it's been asked recently in JIPMER. So if you see, this is the fetal skull image and you have to remember few diameters which are very, very important. So remember, first is a suboccipito bregmatic. Okay, remember SOB. Okay, this is what it is known as. So it is from the suboccipito and we know bregma is this. Bregma means nothing but it's an anterior continent. Okay, so suboccipito bregmatic. This it is 9.5 centimeters. Remember, fetal diameters can be divided into anteroposterior diameters and transverse diameters. Transverse diameters means only one you have to remember, and that will be the biparietal diameter, which we know is 9.5 centimeters at term. Of course, we are talking about at term. Okay, so remember anteroposterior diameter in a well flexed or a fully flexed fetal head, it will be suboccipito bregmatic, which is again 9.5 centimeters. Remember, it's very easy to remember. Also remember that when the baby head engages, so the anteroposterior and transverse diameters are actually the same. So it engages in a, like a circle position, okay? The fetal head. Because of the flexion, the anteroposterior and transverse diameters will be same. Now, if you see this image, in a well-flexed head, I told you circle of 9.5 centimeters will be there. Now, suppose it is a little deflexed, fully flexed head and a little deflexed. A little deflexed head means, now if you see, it will be instead of the suboccipitobregmatic, it's going to be the occipitofrontal. Okay, occipitofrontal. That is more than 10 centimeters. At least you remember that much. It can be sometimes suboccipitofrontal or occipitofrontal, depending upon the level of the deflection. Okay, so if it is suboccipitofrontal, it will be 10 centimeters. Occipitofrontal means 11.5 centimeters. So now you can understand that the anteroposterior diameter is going to be longer, which again it will be a cause for delayed flexion of the head and prolongation of the labor. Coming to the another thing, now there's greater deflection. Now it was fully flexed, mild deflex, now greater deflection. Greater deflection means now it is going to be a brow presentation. Please remember this, okay? It's going to be brow presentation. So they can ask you like this also. कि brow presentation में what is the presenting diameter? So remember, it is the longest fetal diameter and that is mento-vertical. What is mento-vertical? So remember, mento means the chin. And vertical means 90 degree you have to go. So from the chin, 90 degree you have to go. Okay. So this is going to be the longest diameter, that is 14 centimeters. And this is going to be the anteroposterior diameter in brow presentation. Okay. Now coming to the full extension. Now the baby has gone for full extension. So what will happen? Remember, it will be submento pragmatic or submento vertical. Okay. So if you see in this image, what is submento means? Below, behind the chin. So this will be submento bregma. I told you just now bregma. So submento bregmatic. And it's again very easy to remember. It's going to be again 9.5 centimeters. Okay. So you start with 9.5 centimeters and you end with 9.5 centimeters. You start with a circle, you end with a circle. Very easy to remember these diameters. Two other, you have to remember at least occipitofrontal you should know, and the longest fetal diameter 14 centimeters you should know. It is because of this longest fetal diameter that there is no mechanism of labor in a brow presentation because all the pelvic diameters are less than approximately 13 centimeters. So there is no mechanism of labor for such a long fetal diameter. So I hope all these diameters are clear. So moving on to the next question. The drug of choice for PPH, which is resistant to oxytocin and ergometrin. Now, PPH is a favorite every time in all the NEET PG exams. So you should be very thorough with the PPH management. So drug of choice, okay, for a PPH, which is resistant to oxytocin and ergometrin. Read the question very properly because PPH, if they ask what is the prevention for PPH, so remember just now I discussed active management of third stage of labor. This itself is a prevention for PPH, and the most common reason for PPH, I know you are all familiar with 4 T's, that is tonic, trauma, tissue, okay, and thrombin. So I know you all know this, but suppose the option is put something like that. The most common reason is not properly or mismanaged third stage of labor. So again, that will be the most common reason. Okay. So if you see this, recommendations for the prevention, see, read it, read the line for prevention. Okay. PPH does not occur, but for prevention of PPH, 10 units of Synto should be given. Just now I told you any or uterotonic can be given. So in uterotonic, you will include oxytocin, orgometric also. But remember, WHO does not recommend IV bolus. Methergin or methyl ergometrin 0.2 mg IVIM can be given if there are no contraindications. Contraindications means hypertension, anemia, or heart disease. These are the 3 important contraindications for methergin and carboprost. Remember, carboprost is a third line as recommended. And mesoprost, it's a very cheap drug. Something if it is not available, at least mesoprost can be given either orally or even in per rectal mechanism. Remember, every woman in labor is at risk of PPH, and two-thirds of those PPH have actually no identifiable risk factor. So be prepared in all labors. Active management of third stage of labor should be practiced on all females because I told you it prevents 60% of the atonic PPH causes. And all postpartum females should be watched closely, monitored for PPH. Now, these are few updates which you should know that according to ACOG, more than 1000 ml of blood loss irrespective of mode of delivery. Why it has changed? Because before for vaginal delivery, we all know it was 500 ml and for cesarean it was 1000 ml. But now, irrespective of this mode, the value has been taken as 1000 ml. So even in vaginal delivery, now the value has been relaxed to 1 liter. What does primary PPH means? It means within 24 hours. In fact, there is a question, what is secondary PPH? So remember blood loss after 24 hours, but up to 12 weeks. Okay. It was previously 6 weeks. Now it has become 12 weeks. Okay. So these are the 2 important changes you are expected to know. And the treatment protocol of primary tonic PPH. So the first line of treatment is management of shock. For any patient we know, it will be ABC, that is airway, breathing, and circulation. Then management of the uterine atonicity, that you can do by medical management or surgical management. Surgical will be first of all initially conservative, and later on you will move on to radical surgery. So what are the conservative surgical options? Manual removal of placenta, exploration of uterus, and then you have the uterine packing by roller gauze or various such things. The whole idea is to give a tamponade effect. What do you mean by tamponade? Basically, the muscles of the uterus, they have to be compressed so that bleeding stops. And for that reason, you will take help of all these things like condom, Foley's catheter, sex taken Blackmer tube, etc. Then you will move to stepwise revascularization of uterus. Then these are the compression sutures, so I will just discuss. Then you will have internal iliac or the hypogastric artery ligation, and finally postpartum arterial embolization. So this is what I was telling you, stepwise devascularization. So when I say stepwise, we know that the uterus is supplied by the uterine artery. Uterine artery is a branch of the anterior division of the internal iliac artery. Okay. So uterine artery is coming at this point, it is an internal os and it's going to have a upward direction, and lower it will give the cervical and the vaginal branches. So at this junction, at the internal os, first of all, the uterine artery will be ligated on one side, then similar steps on the second side. Also, remember ovarian artery. Now, ovarian artery, remember, is a direct branch from aorta. Okay, aorta is giving a direct branch to ovarian artery. So we will also clamp the ovarian arteries over here. Ovarian artery is actually coming, in the IP ligament. But during pregnancy, there is a very well anastomosis of the uterine and the ovarian arteries. So we will do the ligation of the utero-ovarian artery. Okay, this anastomosis has to be ligated. Again, at one place and then at the second site. So this is known as stepwise devascularization. And these are the compression sutures I was telling, B-Lin suture. So the whole idea is to compress the uterus and check whether the bleeding is stopping or not. So when we have compressed the uterus, you are seeing the bleeding is stopping, and only then you will apply such compression sutures, they can give you these images and they can ask you that what is it. So remember, these is wheel and sutures. The whole idea is to make two loops like this and to compress the uterus. Now you see the compression has occurred. And these are the Cho sutures. Remember, they are like square, okay? So they can again ask you, these are the Cho sutures, okay? Or the compression sutures. And this is an image of the uterine artery ligation. So I know in this actually the fibroids are there, but remember, even for fibroids, the same treatment is there. The whole idea is to inject an emboli into the uterine artery, and this we will do with the help of a catheter being placed into the femoral artery. Now you need to revise your anatomy that aorta is actually going to divide into two common iliac arteries, which will further divide into internal iliac and external iliac. Okay, and external iliac below the level of inguinal ligament is renamed as the femoral artery. Okay, so femoral artery again, if we are going to through the femoral artery, if you see, then I'm going on actually the opposite side. I'm going to the internal iliac artery and then to the uterine artery. Okay, so with one single prick, ipsilateral as well as contralateral uterine artery embolization can be done. And again, it will be the treatment for PPH. So coming back to the question, the drug of choice for PPH resistant to oxytocin and ergometrin, we saw the third line is carboprust. So that answers this question. Sir, is this enough, sir? I think I've discussed for almost half an hour.
Yeah. Sagar, have you felt any laps?
Yes, sir. No, no,
No, no, nothing. I don't.
no, no, no,
I haven't felt. What about the nervous system? I don't think.
no,
It was absolutely
no
smooth.
lag.
Okay.
So, doctor, the thing is, hopingly you have got an intimation from the team that you haven't updated your promo video. That is, hopingly the deadline was given for tomorrow evening. I feel.
Sir, tomorrow, yes, sir, tomorrow I'll do it.
Yeah, it is evening, right? Because I'll be starting to get the intimation from the team. We haven't got. We haven't got. So that as you
So
were
the
here, I
whole
said,
thing, that whole thing, what we have got, we have to speak that, right?
yeah, as it is in the script. But Sagar, you are here only now. You can guide her. I feel.
Yeah, yeah, ma'am.
In the script,
Exactly.
Yeah,
what
ma'am.
is
That would be that.
Yeah, exactly. Those words you have to speak now, or थोड़ा आगे
हाँ,
पीछे हो जाए तो it will be okay.
नहीं चलेगा थोड़ा आगे पीछे तो फिर वो मतलब आपके स्टाइल पे भी डिपेंड
No,
करता है.
no, 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 Sagar.
हम्म.
No need to change the words.
Okay. No,
Absolutely
no,
no
I am
need to change
not
the words
changing the
because
words. I am mainly saying to if anything like that.
No, sir, I'll speak as a script, sir.
no, in
No
the
problem.
sense if the yeah, because the problem is you are supposed to edit that into a trailer, right, Sagar?
Yeah, yeah, yeah.
So we are supposed to like doctor, you change the single small one words in the middle, then it will be no issues. Like in the place of grab, if you use any kind of other words, there is no issues. But the meaning should be same. That's it.
Yes. Should I stop my screen
Like don't
sharing?
change a lot. Okay.
Yeah, yeah, ma'am. You can stop.
Yeah. So Doctor.